aside from the multidisciplinary team, shared decision-making has been a part of lung cancer screening for a while. And the concept of shared decision-making, I think, is ingrained in surgical education, and surgeons guide patients through decision processes, like weighing the potential benefits and harms of surgery, as well as the alternative treatments. What are your thoughts on the surgeon's role in that regard?
Yeah, so really shared decision-making is a partnership with the clinician and the patient and their families, and really going over not just the benefits of any type of test or intervention, but the potential risks of any type of test and intervention, and going through best case and worst case scenarios. I think with lung cancer screening, it's important to understand the benefits. So there's a stage shift. Most patients in this country are diagnosed with lung cancer at stage 3 or 4, the most advanced stages. Most patients who are diagnosed with lung cancer after screening are stage 1 or 2, the best chance for cure. But there are some potential risks for lung cancer screening. For instance, a false positive. You identify an abnormality that turns out not to be lung cancer. And then there are risks with the diagnosis, whether it's needle-guided biopsy or whether it's, and then there's risk with treatment. So whether it's surgery or radiation. But it's all about informed decision-making. And the risks for lung cancer screening are less and less and less as our technology increases. So it's important for patients to be informed, but shared decision-making shouldn't be a barrier to getting equitable access to population health.
Right. And your answer kind of leads into part of my next question. During my training in pulmonary medicine, which was longer ago than I'd like to admit, we had case conferences with thoracic surgeons, and usually it involved at that time decisions around surgery or no surgery, lobar resection for cure or no resection, and almost everyone got a mediastinoscopy. Will you please speak to the changes in philosophy of lobar versus wedge versus segmentectomy, as well as you've mentioned, the changes in technology that have occurred over the last several decades? And here I'm thinking about the development of minimally invasive and robotic techniques, as well as the extension of the bronchoscopic techniques with EBUS and navigational capabilities.
Sure. So when we look at the lung anatomy, on the left lung has 2 parts to it, an upper part, which is called a lobe, and a lower lobe. On the right lung has 3 parts to it, an upper and middle lobe. That's the way it is in every human being, because as we're developing as an embryo, our heart shifts over towards the left. So we only have space for 2 lobes on the left and 3 lobes on the right. Now, each lobe is composed of a segment. So imagine a lobe being like an orange, and you're taking a segment out of an orange. And you could actually cut each of those segments in half or take pieces, and that's called a wedge. So when you have a wedge or a segment, that's called a sublobar resection. So you can either do a lobectomy or a sublobar resection. Now, we have really exciting new data from 2 major clinical trials. One trial was performed in Japan, which they looked at segmentectomy versus lobectomy for tumors less than 2 centimeters in size. That's roughly the size of both my thumbnails put together. And what they found was that in those patients, there was no difference in survival or recurrence of lung cancer in the segmentectomy group. And the segmentectomy group actually did better physiologically wise. And so there was equivalence between segmentectomy and lobectomy in that population. Now, there's new data from an American trial looking at sublobar resection. That's segmentectomy or wedge, just kind of taking a chunk out. And in fact, over 60% of those sublobar resection patients were a wedge and not a segment. And again, no difference in disease, cancer recurrence. And in fact, the sublobar resection patients did a little bit better. So that changes our approach and view of lung cancer in regards to how much lung we actually need to take out. And this is similar to what we learned in breast cancer years ago. We went from something called a radical mastectomy back in the 40s and 50s, where we took muscle and breast tissue and skin out. Then we went to a modified radical mastectomy, where we preserved the muscle, but still took out all this tissue. And in appropriate patients, we moved from modified radical mastectomy to what's called needle localization and lumpectomy, just taking a bit of the breast cancer out, and in this case, augmenting with radiation. And so we're going to see a similar monumental shift in the surgical approach for lung cancer, and that is with smaller wedges or segmentectomies for smaller tumors, giving people an equal chance for cure. Now, we could do this minimally invasively, whether it's video-assisted thoracic surgery or robotic surgery. And now we have the ability to mark little tiny tumors with what's called navigational bronchoscopy, and that's using either electromagnetic navigation or robotic navigation, partnering with our interventional pulmonology colleagues. So these are really exciting advances in the technology for eradicating lung cancer in appropriately staged patients.